So this is the pulmonary embolism, and always remember, pulmonary embolism is one of the most important topic you are going through. This station you will get in critical care station as you are getting here. You will also get in your pathology, especially in coagulation state or and Varcoe triad, and especially in the CQS protocol you also get the pulmonary embolism. So in the different part of your MRCS OSCE preparation, you are going to have the pulmonary embolism in different ways. So I think it's better to prepare pulmonary embolism in a very single attempt, so that you don't have to have a fight on pathology or PDL or the examination or CQIPS examination. You don't need to go for the pulmonary embolism there. So let's start the pulmonary embolism here. So someone please read out the question stem.
Male patient on postoperative day 3, post-sigmoid colectomy due to sigmoid malignancy as tachycardia, tachypnea, shortness of breath and fever, vital pulse 110, oxygen saturation 90% at room environment, respiratory rate 24, blood pressure 110/70, AVGSP 7.49, and partial pressure of oxygen 8, partial pressure of carbon dioxide 3.8, and bicarbonate 24, base excess is 1.2.
Okay.
And stem 2 is
Stem 2.
a 56-year-old patient underwent sigmoid colectomy on the second postoperative day. Patient was found tachycardic along with shortness of breath and fever. ABG was done with which was PA 7.45, partial pressure of oxygen 5 kilopascal, partial pressure of carbon dioxide 4 kilopascal, and bicarbonate 26.
Okay, so we can observe here, come to the stem number 1. We can come to know that both of the stems are postoperative stem, right? This is the postoperative and this is the posterior. So usually in MRCS OSCE preparation, the stems are on the postoperative stations. You will get the pulmonary embolism always from the postoperative station. So one is common, postoperative. So you can see there is a tachycardia and the tachypnea here, and also can see the respiratory rate is 20 breaths per minute, and patient has shortness of breath, heart rate is increased, saturation decrease, blood pressure is okay, AVG is respiratory alkalosis. The same thing, you can go to this stem is also postoperative station, second POD, tachycardia, shortness of breath, fever, AVG, respiratory alkalosis. So let's see what really happens in the pulmonary embolism. It's very vital and very crucial to know during the pulmonary embolism. So one thing, pulmonary embolism is found in which type of patient, Bhaiya? Which type of patient?
Postoperative patient.
Exactly. In the surgical aspect of view, usually the risk factors are the surgery. So at first go for the risk factors. What are the risk factors? Risk factors of the development of pulmonary embolism. You can see the most important risk factors are the abdominal surgeries, or any orthopedic surgery, orthopedic surgeries, even especially lower limb procedures, or lower limb fractures, or even varicose vein surgeries are the commonest example of develop. And especially in both of the two stems, the patient is having malignancy. So malignancy is another risk factors. So these are the risk factors where pulmonary embolism is commonly occurs. Now come to the sign and symptoms. What are the sign and symptoms are found in pulmonary embolic patient? One is patient is having dyspnea. Dyspnea is very common. Patient might have pleuritic chest pain. So chest pain. Patient also may have fever, and especially patient, both of the stem you found the patient is tachypnea and also tachycardia. So as the patient is dyspnea, so tachypnea. So patient is tachycardia. Patient will also have hypotension. We will come to know eventually every single thing, and patient will have especially some signs of DVT, because pulmonary embolism, the main reason of pulmonary embolism is nothing but what?
DVD.
DVT, 95%, almost 95% responsible for DVT. So how's the sign of DVT? Especially swollen leg, especially calf tenderness. So these are the signs of DVT. So when you are going for the pulmonary embolism patient examination, you will have to go for the calf tenderness examination. Okay. Other than those things, they will also have hemoptysis of this patient. Hemoptysis. Now, come to the common source. What are the common sources of the pulmonary embolism? Common source. Could you tell me what are the common sources? Especially, guys, just participate with me. What are the common sources of pulmonary embolism?
Clotted blood.
Where clotted blood is the main thing that will start in the lungs, pulmonary vessels. But from where it is dislodged, especially in the external iliac vein, or that could be femoral vein. Femoral vein, superficial femoral vein, superficial, or that could be deep femoral vein, right? Deep femoral vein. Also popliteal vein, and especially posterior tibial vein. That's why we'll go for the calf tenderness, posterior tibial vein. Here, from these veins, initially there is formation of some clot for any reason. Especially we have gone through these are the risk factors, like patient is having orthopedic surgery, like patient is having
Prolonged
fracture
immobilization.
or for prolonged immobilization. So there is a dislodgement or derangement of the Charcot triad. So as there is a formation or derangement of the Charcot triad, so there is formation of any clot. So initially have a look, clot is formed in the posterior tibial vein. So somehow this clot has been dislodged and it passes to the systemic circulation, then to the inferior vena cava, then to the lungs, ultimately is anchored in any part of the lung or pulmonary vessel. Ultimately, it causes pulmonary embolism. So now trace the pulmonary embolism, how pulmonary embolism really occurs. So I'll go for the details pathophysiology, what is really happening. Then we'll go for the book, go through the book, and you'll come to know that everything is become very easy for you. You don't have to go for the book again. Pathophysiology of pulmonary embolism. Just have a look. This is the heart. For example, this is the heart. I can see it's a very ugly heart. I'm going to have another heart. This is the heart. This is the heart. And this is the, what is this? This is the inferior vena cava, undoubtedly. Exactly, sister. This is the, what is this?
The valve.
Quid valve, tricuspid valve.
Tricuspid.
Exactly. And this one is the pulmonary trunk. And pulmonary trunk is divided into right and left pulmonary veins. And then veins, sorry, pulmonary arteries, right? This is the pulmonary arteries, sorry.
Yeah.
Pulmonary arteries goes to the lungs. These are the lungs. Okay, so trace, I am going to trace the pulmonary embolism, how it really happens. Just have a look. Patient is post-operative period 3 or 4, right side hemicolectomy or something else. Patient is immobilized for a long period of time, or patient is post-operative day of 6 post-operative day of tibia fracture, and he is very pain sensitive and he is not moving, or neck fracture of the femur, not moving. So patient develop some deep vein thrombosis, and deep vein thrombosis is dislodged and become embolus, and this embolus comes to the inferior vena cava. From inferior vena cava, that at first comes to the right atrium, from right atrium, where it comes at first? Right?
Right
What is it?
ventricle.
Ventricle. From ventricle, it goes to the pulmonary
Pulmonary trunk.
trunk. From pulmonary trunk, it goes to the pulmonary arteries,
Lung.
and it is lost or it is stuck, anchored here, and this is the pulmonary embolism. So have a look or go for the consequences. So at first, pulmonary embolism. Pulmonary embolism. So what embolism? So what will be the pulmonary vascular pressure? Will be decrease or increase? Pulmonary
Increased.
vascular
Hyper
pressure will be increased. So
hypertension.
so blood can't go further forward. So what about the pressure of the right ventricle? What about the pressure of the right ventricle? Dr.
Increased.
Anchal, what about the right
Increased.
pressure ventricle? Increase
Increased.
pressure in right ventricle. So dilatation, ultimately dilatation of right ventricle, ultimately it causes failure of the right sided heart failure. So when there is a right sided heart failure, what about the stroke volume? Bhaiya, what about the stroke volume? Stroke volume will be raised or decreased?
Decreased.
Definitely. So stroke volume will be decreased. What about the cardiac output? Increase or decreased?
Decreased.
Decreased.
Decreased. What about the blood pressure?
Decreased.
So we discussed this patient is having tachycardia initially, hypotension, patient is DVT, and there's some tachypnea and chloric chest pain. Now we discussed that these things are happening in the right side. So no blood can go to the lung, and ultimately from the pulmonary vein, no blood comes down to the left atrium. So if right heart is failed or right heart is affected, what about the left heart? Will it be working smoothly?
No.
Definitely no. So left heart
Left. Is
will also be impaired. Will also be impaired. So ultimately, what about the blood pressure? And blood pressure will be decreased. So when there is a blood pressure, what about the sympathetic activity? Increase or decrease? Stimulation of the
increase.
sympathetic nervous system.
Sympathetic.
So what about the sympathetic nervous? So when sympathetic activity is increased, so there will be vasoconstriction. Vasoconstriction, and for correction of the blood pressure, the patient will have sinus tachycardia. Guys, all of you, please just participate with me. What about the heart rate?
Increased.
Because patient have low blood pressure, right heart has been affected, so ultimately left heart also be affected. So no blood can go to the left heart, so ultimately left heart will be affected. So patient will have low blood pressure. As the patient is having low blood pressure, patient sympathetic activity occurs here, and sympathetic activity ultimately causes vasoconstriction and sinus tachycardia. So in both of the scenarios, we have found the patient is having sinus tachycardia. So this is the pathophysiology of the pulmonary embolism. All of you guys, did you get my point? Ultimately, just when you
Yes.
will just going through the topic, you will come to know that pulmonary embolism very, very, very easier for you. Now, come to very molecular stage like lungs. What really happens in lungs? Have a look. This is an alveoli, and this is the pulmonary vessels. These are pulmonary vessels. So through the alveolus, oxygen comes here into the alveoli. So oxygen comes here, and this portion is responsible for ventilation for V, and blood comes here to the pulmonary vessels, and this causes perfusion. So this represents VQ. So have a look here. The patient is having pulmonary embolism. So there is an obstruction in these vessels. So there is an obstruction in these vessels. Did you get my point, doctor? All of you, please. Did you get my
Yes.
point? So there is obstruction. So ultimately, obstruction. So what about the VQ ratio? Will it be normal or mismatched?
Mismatched.
Exactly, VQ mismatch. So as there is a formation of a clot here, there is a formation of the some inflammatory process. And also remember one thing, when oxygen can't come into the pulmonary vessels, there the endothelium of the vessels, these have an special function, that is endothelium contains one type of amino acid that is called arginine. Arginine produces the nitric oxide, and the enzyme is needed here, nitric oxide synthase. And always remember, in the presence of oxygen. Did you get my point, doctor? All of you, please. These reactions occurs in the endothelium of these vessels. So blood, this portion is stuck, no ventilation perfusion occurs here. Ultimately, this portion will deprived of oxygen. So what will about the vessels, bhaiya? All of you. No nitric oxide can be produced. So will the vessel will be dilated or constricted?
Constrict.
Exactly, vessel constriction. So if there is a vessel constriction, what about the pulmonary vasculature? Pulmonary vasculature constriction. So what about the pulmonary tension?
Increase pulmonary.
Pulmonary hypertension. So there is presence of pulmonary hypertension. So also patient is having low oxygen in the blood. So as there is a low oxygen of the blood, the carbon dioxide. So there is a low oxygen of the blood. What about the ventilation? Ventilation will be increased or decreased?
Decreased.
I didn't get you. Annava, please, loudly. What about the ventilation?
Decreased.
Ventilation will be increased. So if the patient is having more and more ventilation and respiration, what about the respiratory abnormalities? Is it respiratory acidosis or alkalosis?
Alkalosis.
Respiratory alkalosis. So if the patient is having more and more breathing, if you guys don't understand how respiratory alkalosis occurs here, just let me know. I can discuss with you. But if the patient is having more and more breathing, the patient is giving more and more respiration, taking more and more hyperventilation occurs here, patient will have some respiratory alkalosis. So tell me, what the respiratory abnormality occurs in pulmonary embolic patient? That the patient will develop respiratory alkalosis. All of you, Dr. Vivek Bhaiya, did you get my point? What about the respiratory abnormalities? Patient will have respiratory alkalosis. Now come to the investigations. What are the investigations we'll go look for? Investigations, and this is the most important thing you will ask in the exam. So in the investigations, at first the commonest investigations will go for, that is the patient will have chronic chest pain, patient will have breathlessness. So the commonest investigation will look for at first, that is the X-ray chest. So what will be seen in the X-ray chest? Is anything will be seen in the X-ray chest? Usually normal.
No.
But there could be some other findings. So let's have a look here. What are the other findings? Like, it is the mediastinum, and there is the bronchial vessels. These are the bronchial vessels, and these are the lungs. So what are the X-ray findings you look for? At first, the commonest finding, at first look at the pulmonary vasculature. There will be enlarged pulmonary artery or dilated Tell me why pulmonary vascular or pulmonary artery is dilated? Why? Why, bhaiya? Why?
Pressure, increase pressure.
Exactly.
Increase
Due to
pressure.
increase pressure. Because there is some obstruction here, somewhere there is a clot formation. Clot have been stuck here, so there will be pressure here. So there will be pulmonary vasculature enlargement. So blood clot has stuck some kind of vessels here. So this portion of the lung tissue are deprived of what? Deprived of blood. So what will happen consequently? There will this portion of the lung is not getting
And
any blood. So what will happen? There will be formation of some infarction, right?
Infarction.
So there is formation of
Which-
some infarction. These things are basically these way. The blood supply are given these way, that wedge shape. So you might have some wedge shaped opacity due to why? Infection. You may also have, there is some obliteration of the angle, costophrenic, cardiophrenic angle. So there might also have some pulmonary effusion. Pulmonary effusion. These are the X-ray finding you can look for in pulmonary embolic patient. So these are the X-ray. Now come to the second portion, and most important is the ECG. So what about the ECG? What are the ECG normal finding in pulmonary embolic patient? Bhaiya, could you tell me someone? Usually ECG usually normal. Always remember, usually normal. So we come to the conclusion that both ECG and the X-ray are normal, but you can also have some finding here. So tell me, in case of immediately or pulmonary embolism, which sided heart is mostly involved, right or left side?
Right side.
Right side.
Right side.
Right side. So at first, what are the findings we will look for pulmonary embolism? What about the heart rate? Heart rate will be increase or decrease here?
Increase.
That's we have discussed here, right? About the heart rate. We have discussed here. Tachycardia, sinus tachycardia. So what we look for in the ECG? There will be sinus tachycardia. One thing. Now tell me how heart rate is calculated. Just have a quick revision. How heart rate is calculated in the regular
300 by the difference
300
between
by
the larger
number of
larger square.
number of square. Number
The RR
of
difference of
large
between
square.
two larger square.
RR distance. Okay, it's the first. Okay, if there's a irregular, so how would you calculate? Please tell me, just tell me quickly.
In a 10-second strip, we count all the
Okay, 10 into
R.
we we calculate all the QRS complexes, all the R waves basically.
no
in a
sister,
10 second.
10 into QRS complex in 30 blocks. 30 blocks. In the 30 blocks, how many QRS complexes are present here? Into 10 is the irregular heart rate. As far as I know, you have already gone through the topic. You have been already discussed about how heart rate are calculated in the regular and irregular rhythm, isn't it, doctor?
Yes.
Dr. Hasnat already told you. So keep practicing. These things are the commonest thing you will forgot in your exam. So one is sinus tachycardia. Come to our point. So one is sinus tachycardia. So the second point is there will be right-sided right ventricular strain. So in case of sinus tachycardia, always remember there will be 49% there will be sinus tachycardia. And in case of right ventricular strain, there will be 34% right ventricular strain. So what really right ventricular strain represent? Always remember there is presence of inverted T wave. Inverted T wave in V1 to V4 lead plus inferior leads. What are the inferior leads? 2,
2,
3
AVF.
and AVF. Now have a look here. Just have a look here. This is a P Q R S T. P Q R S T, right? So there will be presence of T wave inversion, isn't it? There's a presence of T wave inversion. So in case of right ventricular strain pattern, the ECG will be P Q R S T. This way there will be T inversion. T inversion. So while will T inversion present will be in the lead V1 to V4. So where we look for the T inversion, bhaiya, in the pulmonary embolism? In which lead? V1 to
Inferior.
V1 to V4 plus
Four.
minus inferior leads 2, 3 and AVF. Okay. Did you get my point, bhaiya? Okay. Another thing you will have in this type of patient, you will have S1, Q3 and T3 pattern.
E3.
So what are the S1? So in lead one, you will have inverted S. And how lead one really is a negative lead. So these are the lead one. So it is the P, as it is a negative, that's why R is downwards, and you can see it is the S of, and S is inverted. So S inversion. So in lead one, you found S inversion. So it's the S inversion, the first one. And in lead 3 is a positive. That's why you will get Q inversion and T inversion also.
inversion.
So you are supposed to have Q3 plus T3. Have a look here. This is the P, this is the Q, R, S, and this is the T. So have a look here. Q is inverted here. So Q inversion, and T is also T inversion. So have a look. What are the ECG findings you look for? So what are the ECG findings you look for in pulmonary embolism patient? Please, someone, bhaiya, it's very, very, very important. If you haven't gone through those things right now, it would be really difficult for you to properly say in the exam. What are the ECG findings, especially, sister? Please tell me.
So there will be tachycardia, and
Yeah,
also there will be tachycardia due to sympathetic stimulation, and there will also be right ventricular strain, since the right heart will be affected first. And last one is S1, Q3, T3, that is S inversion in lead 1 and inverted Q wave and inverted T wave in lead 3.
And also you can also tell the right axis also deviated, right axis deviation. Right axis deviation. Right.
Because pulmonary
Axis.
right heart.
Exactly. So tell me where left axis will be deviation?
Left
When
ventricular strain or left
both
ventricular
are directed.
No, bhaiya. Especially in which portion left axis will be deviation? Only the left heart failure, especially on the aortic stenosis. Because in aortic stenosis, your left heart is involved. In pulmonary embolism, your right heart is involved. So as it is the right heart is involved, so you will have the right axis deviation, and aortic stenosis, your left heart is involved, so you will have the left axis deviation. Am I clear, bhaiya? Alan bhai, are you clear?
Yes.
Okay.
Yes.
Sometimes I am so pleased to thinking that all of the shining doctors of our country are present with me to break the MRCS OSCE exam, and I'm very much proud. And I didn't even notice, I didn't even think about that I will get so much response within a short duration of time. Okay, I don't know how much I can give you, but remember, I'm trying to give my best.
How many we total?
You are in total almost 36 or 37, and so many are doctors are knocking constantly to participate in the mock session, or somehow we can
Only mock.
only mock, and the and also the recorded classes will be able to provide them, some of them, because some of the courses who run the batches with the recorded classes, and that's why they are requesting us, especially me, to provide those things so that they can, but it's really difficult to me provide those things. Okay. Okay, so what are the first investigation? There is the X-ray. I have discussed all about the X-ray. Then we have the ECGs, and always remember, just make a practice to tell everything about what are the changes in the ECG within 20 to 30 seconds. The third investigation will go for the CT pulmonary angiogram. And always remember, this is a gold standard. So they'll keep asking you, what is the single most investigation you look for pulmonary embolic patient? Tell me, what is this?
CT
angiogram.
angiogram.
Exactly. And we will have to discuss or tell the finding. Just say there is a filling defect in pulmonary vasculature, nothing else. Vasculature. You don't need to tell about the pulmonary vein, pulmonary artery, nothing else. Just tell that there is a filling defect in the pulmonary vasculature. CT pulmonary angiogram showing filling defect in the pulmonary vasculature, nothing else. Now, another investigation, that is, we can go for the VQ ratio or VQ scanning. So whatever the VQ scanning, ventilation is okay. So there is no problem with the coming of the, just have a look here, no problem with the coming of the oxygen here, right? So there the oxygen is normal in the alveolus at first, but problem with what? Problem with what? Perfusion. So our problem is the perfusion. So Q is decreased. So what about the ratio? Ratio will increase or decreased?
Increased.
Increased. So you will be asked, what about the VQ ratio will go for or look for pulmonary embolus? So definitely the ratio will be increased. Then you can also go for echo, 2D echocardiogram. You can go for D-dimer, and especially at last, not the least, the most important, you go for AVG analysis. AVG analysis. So what will look for? What are the look for?
Alkalosis.
Pulmonary alkalosis or respiratory alkalosis. So what are the pH proportional to bicarbonate divided by partial carbon dioxide? So tell me, what will happen? What are the findings we'll look for? At first, carbon dioxide will be increased or decreased?
Decrease.
Decrease. Carbon dioxide decrease, right?
Decrease.
What about the pH? pH will be
Increased.
increase. What about the bicarbonate for the compensation?
Bicarbonate will
Decrease.
decrease.
Decreased.
Bicarbonate will also be decreased. So these are the findings you will look for the pulmonary alkalosis. Am I clear, guys? Please tell me, am I
Yeah.
clear?
Yes.
Yes.
Okay, so
Bhaiya,
someone please.
bicarbonate will be increased, Bhaiya. pH.
No, sister.
No,
Yes,
more
sister.
ventilation, so decrease
Dr.
carbon
Badhan,
dioxide.
I think I should take a session on AVG analysis, and that will be only dedicated
Okay,
for
Bhaiya.
you. And I'm having
Bhaiya, but here is the proportion. The proportion
no
says
problem.
that pH is proportional.
Okay. That's why you need a session for pulmonary or the AVG analysis. But look here. This is the primary defect, and pH always is proportional with the primary defect, and this is the secondary defect that occurs due to this change. And carbon dioxide decrease, that means there is a pulmonary respiratory alkalosis, and always remember, respiratory alkalosis is compensated by metabolic acidosis, and in case of metabolic acidosis, bicarbonate is decreased. Did you get my point, sister?
Okay, Bhaiya. Yes, Bhaiya.
Okay, now someone tell me, what are the investigations we'll go for? Just within 10 seconds, what are the investigations we'll go for?
Just
Chest X-ray will chest X-ray initially it is normal,
Mhm.
and ECG we can find is normal, but there may be some changes. The ECG in the ECG we can find
What are the changes we look for, Bhaiya? What are the changes we look for?
we look for sinus tachycardia.
No, in
Tachycardia
X-ray,
and
Alan bhai, in X-ray.
in X-ray we may find wedge-shaped.
There is a pulmonary vascular artery dilatation, right? Due to increased pressure. Wedge-shaped opacity due to infarction.
Opacity,
Infarction.
yes.
And the pulmonary
Infarctions.
effusion. Dr. Bhadan, could you tell me what are the ECG changes we look for? ECG changes?
Yes, Bhaiya. ECG changes will be the right ventricular strain, which will be inverted T wave in.
No,
we
at
want
first
to
tell
wait
about the
for lead.
sinus tachycardia. At
Okay,
first,
sinus
mention that.
tachycardia. So there will be increased heart rate, and then there will be right ventricular strain, which will be inverted T wave in V1 to V4 plus in inferior leads, and then we will have S1Q3 T3, which is S inversion in lead 1 and Q and T inversion in lead 3.
Okay. Okay. What are the other investigation, Dr. Who is this? Dr. Oshim? What are the other investigation we look for?
Other investigation are CT pulmonary angiogram, VQ ratio scanning, echo, D-dimer, and ABG analysis.
Okay. So what are the ABG finding we look for?
We look for ABG finding, that is respiratory alkalosis may present.
What are the changes in respiratory alkalosis?
The pH will increase, decrease partial pressure of carbon dioxide. In a compensatory state, there is decreased bicarbonate.
Okay, that's great. That's great. Now, come to the management of the pulmonary embolism. How would we manage the pulmonary embolism? Pulmonary embolic patient are usually placed in 2 or 3 categories. Those are non-massive. Sometimes they are classified into moderate, or sometimes those are massive. So let's categorize 3 types. One is non-massive pulmonary embolism. Another one is moderate pulmonary embolism, and another one is massive pulmonary embolism. Massive pulmonary embolism. So these are the 3 types. Always remember, if there is a pulmonary embolism plus patient is hemodynamically unstable, then the patient is called massive pulmonary embolism. Did you get my point, doctor? All of you, please. When the patient is called massive pulmonary embolism, the patient is pulmonary embolism and patient is hemodynamically unstable, then it is called massive pulmonary embolism. Okay. Massive pulmonary embolism is again divided into 2 types. There is low bleeding risk, and the high bleeding risk. So come to the non-pulmonary embolism. Non-massive pulmonary embolism. In non-massive pulmonary embolism, we only use low molecular weight heparin according to local trust policy. Simply mention the low molecular weight heparin, nothing else in the non-massive pulmonary embolism. In case of massive moderate pulmonary embolism, we use low molecular weight heparin or catheter directed or surgical embolectomy. You can mention this thing or you can ignore these things, no problem. You can just mention this thing, non-massive or massive, that's okay. But you can also this moderate pulmonary embolism comes recently with our guideline, but you can also ignore those things, no problem. But always remember, non-massive pulmonary embolism is low molecular heparin is the mainstay of treatment. Now come to the massive pulmonary. So when we'll call the massive pulmonary embolism, when we'll call a patient is in massive pulmonary embolism, when? Exactly. Okay. So if there is a there is a low bleeding tendency, so our treatment will be surgical embolectomy plus or thrombolysis by tissue plasminogen activator, and this is the full dose IV directly you will infuse the blood. Thrombolysis by tissue plasminogen activator, and this is the surgical embolectomy. If patient is highly risk of bleeding, so you can also treat the same way, surgical embolectomy. But remember, full dose or direct tissue plasminogen activator is contraindicated here because there is a high bleeding risk. So you
Bleeding
can
chance.
exactly, bleeding chance is high. So you can give tissue plasminogen activator by catheter directed thrombolysis. Did you get my point, Bhaiya?
Not
All
to
of
the
you?
not to the circulation.
Exactly.
Right.
So here as there's a low bleeding tendency, so you can give the circulation full tissue plasminogen activator, but as this is a high risk, so you will have to give the tissue plasminogen activator through the
Locally.
catheter. Exactly. So these are the pulmonary pharmacological treatment. Did you get my point, doctor? All of you, please let me know.
Yes, madam.
Okay. So let's go for the stem right now again. So what are the differential diagnosis? Or differential is pulmonary embolism, chest infection, basal atresia, sepsis, so many things you can go for. What are the ECG changes? We have,
Doctor
Bhaiya, please.
Dr. Rifat,
Yes, Bhaiya.
is a second PUD. So
Mhm.
is it possible for the first choice of pulmonary embolism? Because DVT takes about 7 days
It's
to
a
happen.
5-6 days, Bhaiya. It's a 5 or 6 days. But what are the things? Especially, I think basal atresia comes earlier, right?
Yes, the question is a second PUD and third PUD, not over
Exactly.
that.
I am
So first
completely
diagnosis,
I'm completely agree with you because for development of the pulmonary embolism will take 6 or 7 days, 5 days is also correct. But earliest respiratory complications are the basal atresia and other things. These are
yes,
the so.
first basal atresia
But
chest
I
infection.
think
This is within 2 or 3 days.
days, exactly 2 days. So I think in your real situation that won't be there because those things are the recall. So you won't get the all the questions directly, right? So these are the some fabricated, some missed information comes here. So just make it 6 or 7 days. 6 or 7 days. Makes it 6 or 7 days. Did you get my point,
Bhaiya, one
guys?
thing.
Please.
Since the patient has sigmoid malignancy and it is also a risk factor for
Exactly, that
formation of
also
DVT.
high susceptible to development of DVT, but it is very unlikely to develop within 2 days. Bhaiya.
Okay.
Main blood clot source from the legs. So immobilization needs some time.
Bhaiya, but one thing is, I'm totally agree with Dr. Mahathir that one thing regarding the if the DVT is formed due to immobilization, that is for 5 or 6 days. But if there is any malignancy, in case of malignancy, there is blood is hypercoagulated state. There's a chance of development of more and more coagulation cascade. So that also will happen. So, but
I
always
think
remember
this is not usual.
exactly. So always remember if you are getting a patient is post-operative state and patient is having breathlessness and respiratory distress and patient is having respiratory alkalosis, don't dare to tell anything other than pulmonary embolism. I am requesting you, don't try to be a superhero in the exam hall, because if you are going to
we
say
have to
anything,
memorize that if this type of extension comes, we will say, so this is pulmonary embolism.
Pulmonary embolism. Don't try to be a superhero in the exam. Definitely, if you try to be a superhero in the real exam, you will definitely fail in the exam. I can assure you, especially on those station. Did you get my point, Bhaiya? All of you, Dr. Mahadi Bhaiya, please say something. Did you get my point? I don't know, I don't understand whether you're getting me or not, because you are very new today.
I think Mehdi bhai has the headphone issue.
Okay, no problem. So what's your differentials? So you try to like this. What are the EC changes? S1, Q33, right axis deviation, sinus tachycardia. You will get all those things. So these are the X-ray. You can have a look here. Why suspected pulmonary hypercoagulable state, and patient is tachycardia, tachypnea, decreased oxygen, and post-operative patient. They're going to show you AVG. What are your diagnosis? In case of AVG, what are the diagnosis? Respiratory alkalosis. And patient is having low oxygen.
I have a query. I have a query to you.
Sure.
Yes, I agree that this patient has more and more ventilation, tachypnea, but the patient is feeling more pain, sudden pain. So with this pain, is it possible to make more ventilation, because the pain resist him or her?
I think the pain is not the main issue here. Patient is not getting the oxygen. That's why patient will keep going for more and more respiration, because he is not getting the oxygen. And pain is not that much important here, because there is no direct trauma or anything. There is a stack of the
this is ischemic pain, sudden.
Yes. Pleuritic pain, basically. Pleuritic pain.
The symptoms, when these symptoms, sudden chest pain and respiratory distress. So this is the symptoms. Usually symptoms is sudden chest pain and respiratory distress. So with that, this is my query. I'm not.
You are absolutely correct. I think the oxygen exchange is the main issue here. Then pain will come, because any respiratory alcoholic patient, ultimately, if his condition is ongoing on that state, that patient will ultimately develop respiratory acidosis, and type 1 respiratory failure ultimately goes to the type 2 respiratory failure. So initially that patient
will be shallow breathing. It will not be proper breathing. It will be a shallow breathing.
Exactly, rapid breathing. And you can see the scenario here, that the respiratory rate is 28 or something else, 24. Shallow breathing, exactly, and the rapid breathing. Am I clear, Bhaiya?
Yes. So you have to memorize that rapid breathing. Here,
okay, just have a look here. Have a look here. I have discussed it here. Ventilation is increased, so patient will have respiratory alkalosis.
Okay,
that's great.
I have a question. In the X-ray, do we see anything? Because I cannot understand what.
Okay, in this X-ray, I think nothing is seen in this X-ray, because only thing is the vasculature is prominent here, nothing else.
I think it is normal.
These are the normal. Something is just dilated vessels, nothing else. Nothing can be seen. These are the these are the normal X-rays. Okay, so the main thing they will ask about the CTPA, AVG analysis, and ECGs. Nothing. They are not concerned about the X-ray here. So what do you think the patient is having respiratory alkalosis? Why patient is having respiratory alkalosis?
Hyperventilation to wash.
Exactly. What's the ECG step here? What's the finding? Just you will have to take everything about the ECG finding. What is the CTPA finding? Just tell me, what is the CTPA finding? What did I say?
Filling defect.
Exactly. Only go for the filling defect in the pulmonary vasculature, nothing else. Just don't try to say anything other than this six. Filling defect in the pulmonary vasculature.
When you see the ECG in the examination, just we will say from our memory.
I just want to say one thing, that you will be asked so many questions in the pulmonary embolism or any other critical care stations, and it will be really difficult to really have the finding from the ECG. Just note it down how I am saying. Just try to just say everything that are usually present in the pulmonary embolism in the ECG. Just go for the ECG findings. They won't ask you, just show me where is the key S1, where is the Q3, where is the T3. Those things they won't ask you. They
And
simply ask you
will
what is
give
the finding of the ECG, nothing else.
Just we have to
say
say
for-
from our memory.
Exactly. Dr. Anchal, are you saying something?
Yes, I was saying for the CT, do we have to point out where the filling defect
No,
is?
no, you don't have to point out, but have a look here. These are very simple here. So this is the pulmonary vasculature, and there is a filling defect. This is the filling defect. This is the filling defect. Do you get my point?
Yes.
Okay. So pathogenesis of clot formation, I have already just discussed about the coagulation skate. So what are the first step? One is what was the steps of the coagulation or hemostasis?
Endothelial injury.
Initiation is endothelial injury. That's okay. But what is the
Endothelial
stage?
injury.
What is the first stage? Vaso.
Platelet plaque formation.
Era kere? Who is this?
Vasospasm.
Vasospasm. Who was that? There's a first vasospasm. Tell me why vasospasm? One is that Anchal, just tell me
Thromboxane
why.
A2.
Exactly, thromboxane
The
A2.
smooth muscle contraction.
Exactly, smooth muscle injury or muscular reflex or myogenic reflex. Another one is nervous reflex. You forgot everything. You forgot everything. Second one is platelet plaque formation. Plaque formation. Third one is
Aggregation first.
steps of coagulation. These are the steps of clot formation. Did you get my point, Dr. Manara? Did you get my points? Bhaiya?
Yes.
Okay. Dr. Vivek Bhaiya, I don't know where is he. So how to approach the patient, how to manage the patient? As I was saying, CQS protocol, airway, breathing, circulation, those things are the same thing. Then pain relief, ITO, inform my senior. Then what are the investigation you look for if the patient is non-massive? Just have a look at quick revision. Patient is stable and non-massive, low molecular weight heparin according to the
only low molecular weight heparin.
Exactly. If moderate, low molecular weight heparin, catheter guided or surgically embolectomy. Did you get my point?
Embolectomy is possible.
Okay. If the massive is divided how many types? One is
Two types.
Two types.
Low bleeding
Low risk of bleeding,
high risk.
high risk of bleeding.
If low bleeding risk, surgical embolectomy, full dose tissue plasma activated.
Of systemic
Exactly.
yes.
Tissue IV. And if the patient is high risk bleeding, then we'll go for the catheter directed thrombolysis by tissue plasma activator and surgical embolectomy. So this is the management of this patient. And definitely they will ask, they look for only this portion only. Did you get my point, Bhaiya? All of you, please tell me.
Yes,
did you get my point?
Yes.
What is the trust protocol? What is the trust?
Who is this? Dr. Latif. Trust. What is the trust? This is the trust is the NSH, National Health Services. All the hospitals are directed by a authority, that is the trust, and they do have some protocols usually for the local hospital, like in a hospital that
like
is
nice protocol.
Not that kind of nice.
One kind of nice.
But these things are locally directed.
But nice protocol is not universal, but is initially is used for the NHS hospital, but it is widely recommended after that.
Yes, but trust is locally. Like some hospitals in Dhaka, some hospitals are in Chittagong.
Yes, local. This is the local institute has.
Few infections are common in Dhaka, few infections are common in Chittagong.
Yes. I agree with that. This is particularly for that institutions.
Exactly.
That depends on the environment, depends on the evidence. Evidence-based protocol.
Yes, that is the trust protocol. Did you get my point, Dr. Latif? I don't know whether I get it or not. Okay, that's good. So you are in the OT and scrubbed. Now tell you about the pulmonary embolism and another patient in the ward. What will you do? I'll inform the consultant and I2 register. Start low molecular weight heparin. CRASH, CRASH, crash code. Just correct it. Crash code. It's a recall question. These are the things we'll have to do. So I think that's all for pulmonary embolism. Now we'll start for the see. Is there any question?